Thank you very much. It's 5:04, so we can start this new ERN webinar. We are really happy to be here today, and I think that it's a great panel that we have this afternoon. We have plenty of information to share, and I'm really looking forward what our speakers will share with us. I have the pleasure to co-share this webinar today with Dr. Jacopo Olivotto, which will connect in few minutes. And I have the pleasure to be together with Dr. Cordula Wolf from Munich, Dr. Andrea Greco from Barcelona, and with Dr. Alessia Argiro from Florence. So we are really happy to talk about something that worries us a lot, which is gene therapy in pediatric cardiology. It's a topic that we are really expecting a lot from it. And so we feel really hyped, but we want to learn from the people who is already there with wet hands working on that. So it's really a pleasure to talk with them this afternoon. So we will start with a pediatric case, an adult case, and then we will have the pleasure to hear what Dr. Cordula Wolf is sharing with us. So we will start with Dr. Andrea Greco from Sant Joan de Déu, Barcelona.
Yeah, thank you very much, Georgia. Good afternoon, everyone. Thank you very much for the invitation to this beautiful topic, this beautiful webinar. So today I will present a clinical case of a severe pediatric hypertrophic cardiomyopathy, which probably illustrates both the complexity of managing early onset sarcomeric disease and the potential role of a gene therapy in pediatric cardiology. So starting with the case, this is the case of a 7-year-old girl who was diagnosed with an hypertrophic cardiomyopathy at 1 year of age. So the diagnosis was made after a family screening following the diagnosis of hypertrophic cardiomyopathy in her older sister. So the family history was highly relevant in this patient. So her older sister was as you can see here in this family pedigree, the index case, and suffered from a sudden cardiac death at the age of 7 years. So genetic testing in this sister identified a compounded heterozygosis variants in MYBPC3, a paternal variant and the maternal variant. The father in this case has a hypertrophic cardiomyopathy phenotype, but the mother has no clinical phenotype. So this pedigree was already suggested of a compounded heterozygosis mechanism associated with a much more severe pediatric presentation in these children. So our patient was found to carry the same compounded heterozygosis MYBPC3 genotype. And this is important because, as you know, this gene encodes the cardiac myosin binding protein C, that is a key in the sarcomeric protein that involved in the regulation of the myocardial contraction and also the relaxation. So in this patient at 2.5 years of age, this was the baseline phenotype. This was already very severe. So she had a non-obstructive hypertrophic cardiomyopathy with a restrictive physiology. So there was significant diastolic dysfunction, mild left atrial dilatation, and preserved left ventricular ejection fraction at rest. So she also had a small atrial septal defect or a patent foramen ovale with left-right shunt. And the key point in this first evaluation is that although the systolic function was preserved at rest, the physiology was clearly abnormal, with a restrictive physiology. So we performed a cardiac MRI at the same age. And interestingly, there was no LG. However, we know that the absence of LG did not mean a benign phenotype, as the patient already had severe diastolic dysfunction and later developed major arrhythmic events. So in this case, clinical severity was driven not only by the fibrosis, like in adult cases, but likely by the sarcomeric dysfunction. So this was the baseline ECG that shows a sinus rhythm with increased QRS voltage, diffuse increased QRS voltages, deep inferior Q waves, and ST segment abnormality. And these findings were consistent with the hypertrophic cardiomyopathy phenotype. And as we know, the deep Q waves that you can see in leads free, above all in leads free, are important markers of abnormal ventricular activation and repolarization. No? So the initial treatment in this patient includes beta blocker therapy, and given the family history of sudden cardiac death and the severe phenotype, a close written surveillance was established with an implanted loop recorder. And in this patient is a very important decision because the patient was still very young. In the loop recorder later documented the first major arrhythmic events. So at 3 years of age, during a respiratory illness, she developed vomiting, pallor, and a syncope. This was followed by hypotonia and unresponsiveness. And the implanted loop recorder documented a ventricular fibrillation. So this was in this patient a turning point in the clinical course because after this episode, an ICD implantation was indicated for secondary prevention. So in November 2021, at 3 years of age, she underwent implantation of a transvenous single-chamber ICD for secondary prevention. As the decision to implant an ICD in a young patient is never simple, no? It involves, you have to balance the risk of sudden cardiac death against the device-related complication, no? And long-term burden of the device therapy. So, however, I think that in this case, the indication was clear. So in September 2022, she developed symptomatic atrial tachycardia. So the arrhythmia was poorly tolerated from an hemodynamic perspective. And this is not surprising, no? Because with this patient with restrictive physiology depend heavily on the way diastolic filling time and with the atrioventricular synchrony. So in this patient, an electrophysiology study was performed that it shows no sustained atrial tachycardia, but the arrhythmias in this case was difficult to map because it was not sustained. So medical treatment was changed and intensified. She was treated with sotalol and ibabradi. No? The rationale was to reduce the arrhythmia burden, to control the heart rate, and to avoid excessive tachycardia. No? But in the same time, to try to preserve the diastolic filling time. So during the follow-up between 2023 and 2025, the phenotype remained persistent with a preserved left ventricular ejection fraction, but significant diastolic dysfunction and restrictive pattern. So in the routine ICD checks did not show appropriate therapies or major events during this period. And in July 2025, an exercise testing provided us very important information. So during the test, she reached a maximum heart rate of 155 beats per minute. At this heart rate, she developed pallor, cold extremities, weakness, and severe hypotension with blood pressure dropping over 45 millimeters of mercury. And the ECG showed ST segment depression in the inferior leads. And this response was interpreted as a low cardiac output and myocardial ischemia, not triggered by the tachycardia. So in this physiology, her systolic function was preserved, but under stress, when the heart rate increased and the diastolic filling time shortened, she developed hemodynamic collapse and ischemic ECG changes. So it was in line with the exercise intolerance that have been reported by the parents during the daily life activities. So to better understand this physiology, a combined hemodynamic and electrophysiology study was performed in July 2025. So as you can see here, at the baseline, the heart rate of 60 beats per minute was, we don't see any changes. However, during atrial pacing at 150 beats per minute, she developed ST segment depression, ventricular, severe left ventricular systolic and diastolic dysfunction, and finally, as you see before, ventricular fibrillation that require an external defibrillation with the restoration of finally of the sinus rhythm. So this study confirmed the mechanism that we suspected during the exercise testing. So the tachycardia causes severe hemodynamic deterioration, ischemia, and secondary to this, a malignant ventricular arrhythmias. So after this study, the therapeutic goals become very clear. No, the first goal was to avoid tachycardia. The second was to improve the diastolic filling time. And the third was to reduce the ischemia during distress. And finally, the treatment had to prevent both atrial and ventricular arrhythmias while maintaining normal or acceptable blood pressure. So based on this, the treatment was optimized with sotalol, ivabradine, and then we had verapamil. So in this case, the addition of verapamil was intended to improve the diastolic function, to reduce the heart rate response and to reduce the ischemia, improving the balance between the myocardial oxygen supply and the demand. So we repeat an exercise test 1 month later, and after the introduction of the verapamil, at this time, the maximum heart rate was lower, around 130, 135 beats per minute, reflecting a reduced chronotropic response under the new treatment with verapamil. And importantly, she had no symptoms, no hypotensive collapse, and no ECG signs of ischemia. So this was clinically meaningful, no? An improvement, an important improvement. It suggests that controlling the heart rate response and improving the diastolic filling time could reduce the inducible, in this case, ischemia, and improve the hemodynamic tolerance during distress. In October 2025, we perform another assessment. So myocardial biopsy samples were obtained from septal, septoapical, and septobasal region together with a skin biopsy. An electrophysiology study was repeated, and non-sustained arrhythmias were inducible. We see only mild QRS widening and ST changes during the atrial pacing. So actually, she is clinically stable, but with important limitation in daily life activity. She remains in sinus rhythm with an heart rate around 50, 55 beats per minute at rest. Echocardiography shows stable findings. ICD interrogation shows no events and stable leads parameters. And her current treatment includes sotalol, ivabradine, verapamil, and we had recently dapagliflozin. So at this time, we achieved a degree of clinical stability, but we have an intense medical therapy and significant activity limitation, and above all, the daily life limitation. So the next step right now is that she's currently being prepared for first in pediatrics TN-201 gene therapy administration for gene therapy of MYBPC3 associated hypertrophic cardiomyopathy. And to say something about this, only a few words about the TN-201, that is a AAV9 based gene replacement therapy that is designed to deliver a functional MYBPC3 transgene to cardiomyocyte with the aim of increase the cardiac myosin binding protein C levels and addressing the underlying genetic mechanism of the disease. And is designed as a gene replacement approach, so it delivers a functional MYBPC3 gene to cardiac muscle cells, aiming to restore the myosin binding protein C levels. So there are several reasons why we are going to use this gene therapy in this patient. So she has a severely onset sarcomeric cardiomyopathy. She carried a compounded heterozygosis in MYBPC3 variant, which are associated with a particular severe phenotype, as you can see in this clinical case. Her disease is not a typical obstructive hypertrophic cardiomyopathy. It is a non-obstructive hypertrophic with a restrictive phenotype cardiomyopathy characterized by severe diastolic dysfunction and limited ability to increase the cardiac output during stress, exercise test. Then she had a malignant arrhythmia history, included a documented ventricular fibrillation and ICD implantation for secondary prevention. She had demonstrated hemodynamic vulnerability with tachycardia-induced ischemia, low output cardiac output, and pacing-induced ventricular fibrillation during invasive assessment in the EP lab. And finally, despite optimized conventional therapy, she still had major limitation in daily life activity and remain at risk. So probably for all of these reasons, she represents a strong candidate for this type of therapy. So thank you very much.
Thank you, Andrea. I think this is a very interesting case. I think we will keep all the questions that you could upload in the chat next to next to the screen, and we will comment on them at the end of the session. So, Alessia, I think that it's your turn, and we will be more than happy to share with you. And welcome, Jacopo, that you are here, and I'm so happy that you are co-sharing with me this session.
Thank you so much. Sorry for the late connection. I was giving another talk, but happy to be here.
Thank you, Jacopo.
All right, so thank you very much for inviting me today. My talk will be about Danon disease. I structured this presentation in 3 parts: a brief introduction and 2 brief clinical cases. So Danon disease is a rare disease and is due to loss of function variants in the LAMP2 gene, which is localized on the X chromosome. The inheritance pattern is X-linked, and men and women have a different natural history in this condition. The LAMP2 variants determine a deficient production of the LAMP2B protein, which is involved in macroautophagy. Macroautophagy is a process through which the cell degrades glycogen and other cellular debris, and its impairment represents a trigger for the development of a severe form of hypertrophic cardiomyopathy. Diving a little bit deeper into this pathophysiology, we can see that LAMP2B allows diffusion between the lysosome and the autophagosome, and its deficiency doesn't allow this process. And therefore, inside the cardiomyocyte, we can find several vacuoles and hypertrophied cardiomyocytes. And the deficient macroautophagy eventually leads to cellular death and fibrotic replacement that in this condition can be extremely extensive, as we can see in the histological and macroscopical specimen. LAMP2B is expressed mostly in the heart, in the brain, and in the muscles. Therefore, Danon disease is a systemic condition, and systemic manifestations can include proximal myopathy, neurocognitive impairment with learning disabilities and mild cognitive deficits, psychiatric manifestations with anxiety and mood disorders, retinopathy, hepatomegaly, and elevated liver enzymes. As we have said, Danon disease have a different manifestation in men and women. In this cohort, we can see that men are diagnosed earlier compared to women, with a mean age of 13 years for males and 36 years for women. Males present a greater left ventricular thickness, but women more frequently evolve into a hypokinetic dilated phenotype. Both men and women present a remarkable arrhythmic propensity with Wolff-Parkinson-White syndrome, AV blocks, atrial fibrillation, and ventricular arrhythmias. While in male, the condition is usually systemic, in women, the disease can be manifested by the sole cardiomyopathy. In this survival curves, we can see that in blue and green are represented males, and usually males need transplantation by the 3rd decade. In women, in orange and red, the complications of the disease usually start after 40 years old, and the survival curve is less steep compared to men. Now we will begin with our clinical cases. In this first clinical case, the history of the patient begins while he was 12 years old. He was a competitive basketball player, and he was referred to our cardiology clinic by sports cardiology due to ECG abnormalities and mild left ventricular hypertrophy. On Holter, he had no major arrhythmias, and on stress echo, he had no alveolar obstruction. We follow up the patient, and over the years, he developed marked abnormalities on echocardiography and electrocardiography. He underwent a genetic testing that showed LAMP2B pathogenic variant, leading to the diagnosis of Danon disease. On lab test, he had increased liver and muscle enzymes, but no overt myopathy. He was implanted with an ICD, and he had an appropriate ICD intervention during intense physical activity. These are his ECGs. While he was 12 years old, the abnormalities were already extremely marked, with increased QRS voltages, T-wave inversion in lateral leads, and deep Q waves. And over the years, these abnormalities worsened. On echocardiography, he started with a mild left ventricular hypertrophy that after only 3 years became massive. The CMR was concordant with these abnormalities. We had at the beginning only mild left ventricular hypertrophy, and on LG, he had no fibrotic replacement. And after 3 years, the hypertrophy became really massive, as we can see. And he developed extensive fibrotic replacement. On the mapping, due to the fibrosis, it showed increased T1 and increased extracellular volume. We will go to the second clinical case. In this case, the diagnosis was made due to family screening. His mom was affected by Danon disease, and unfortunately, she died on the transplant list. The patient was implanted with an ICD when he was 12, and he had inappropriate shocks while he was playing with other friends. And when he was 16 years old, he developed atrial fibrillation. He was started with anticoagulation that was treated with cardioversion and antiarrhythmic therapy, obtaining optimal rhythm control. However, the patient experienced several AFib recurrences. Flecainide was replaced with amiodarone that was stopped due to hypothyroidism and increased transaminase. And over time, his heart failure worsened, and in 2024, he developed NYHA class 3 heart failure. His heart failure therapy was implemented with SGLT2 inhibitor, potassium caronate added to his beta blocker therapy. And he was referred to the local transplant center and is now enlisted for transplant. In order to achieve, again, rhythm control, he underwent a cryoablation of pulmonary veins, but in the same night of the procedure, he developed 221 flutter, and that was treated with electrical cardioversion that, however, was ineffective, and he was discharged on rate control with nadolol only. So this was his echo when he was 12 years old, and we can see an already marked left ventricular hypertrophy, with hypertrophy also of the papillary muscle, but an hyperdynamic left ventricular function. We have the echo over the years, and we can see that after a couple of years, the LV starts to become dilated. And here the patient is in AFib, and the ejection fraction is preserved. It's still preserved. And I will show you his latest echo. And now we can see a markedly dilated LV cavity. And, sorry about the sound, and markedly reduced ejection fraction that is evident here in the apical four-chamber view. So we have seen 2 patients in different stages of the disease. we can summarize the natural history of Danon disease with a rapid phase of increase of LV hypertrophy that reaches a plateau and remains stable. The ejection fraction is hyperdynamic or preserved, and gradually the ejection fraction starts to decline, and this is mirrored by the appearance of progressive heart failure. Danon disease is a target of gene therapy, and in this condition, it's hard to find the right stage when we should perform the gene therapy infusion. The optimal stage is, of course, when the ejection fraction is still preserved. And it's very important to identify the patients in this stage because the decline when this ejection fraction starts to reduce can be very, very rapid. So concluding, Danon disease is a rare and potentially fatal condition. It's due to variants in the LAMP2 gene on the X chromosome that can lead to macroautophagy impairment. It's characterized by a severe and rapidly progressive hypertrophic cardiomyopathy and can progress towards advanced heart failure. Ventricular and atrial arrhythmias are frequent in this condition. Thank you for your attention.
Thank you very much, Alessia. I think once again these are amazing cases. As we said with Jacopo, I think that we have a great bunch of junior and not that junior cardiologists and pediatric cardiologists which do a great job, and I think those have been nice examples. Thank you so much. And so Jacopo, would you like to introduce Cordula?
Yes, absolutely. So Cordula is a fantastic clinical investigator and cardiologist. She has probably the most extensive experience with gene therapy in hypertrophic cardiomyopathy right now, and she's again a fantastic, very passionate cardiologist. Any age, I guess, you see patients in 0 to 99, right? So it's my pleasure to hand over the podium to you.
Thank you, Jacopo. Pleasure. So let me share my screen. And I just have to, hold on. No, wrong one. Sorry. One more time. All right, can you see the slides?
Yes.
Yes.
Okay, perfect. So I'm going to talk about the clinical reality of gene therapy, and thank you so much for inviting me. Those are my conflicts. So we heard two wonderful cases by Andrea and Alessia. And on top of those two patients, of course, there's many more with cardiomyopathies. And I just wanted to point out in this slide that there's all these genetic causes of all these different cardiomyopathies, and that gene therapy really is going to be the treatment of future for hopefully most of these patients affected. And this is summarizing in this slide basically where we are right now. I hope you see my mouse. So right now, I think most of the time we are treating symptoms in these patients. We do have some small molecules now in our hands, such as myosin inhibitors, which have recently been approved for sarcomeric HCM. So we do have some treatments on the protein and cellular level. But ultimately, what we really want to do in cardiovascular precision medicine is to treat the disease at a genetic level so that those patients do not even express the symptoms anymore. And how can we do that? So now we are going into the field of gene therapies and nucleic acid therapies. And I wanted to show you some overview on what there is out there right now, which is being approved, which is under investigational trials right now, and what the safety problems are that we are facing with right now. So this is the AAV9 delivery system, and that's the one that's mostly and commonly used. It is an adeno-associated virus that delivers the transgene into the cell. It does mimic the infectious process. Hence, it binds to the cellular surface, it internalizes, it traffics to the nucleus, and there it really releases the genetic material so that transcription to the protein can result. And Andrea already showed this. This is the product that Tenaya has developed and that has been shown in a phase 1 to be safe and effective. It's an AAV9 vector as well. We use these vectors in the cardiovascular and specifically the cardiomyopathy field because those are very cardiomyocyte-specific vectors, which is due to their promoter that they built on this transgene. So this is just to show you that there is a capsid, which is the attenuated adenovirus, and that capsid contains the transgene that we want to transduce to the patient. And regarding which one, of course, it depends on which disease you want to treat. So you need to look at which genetic defect you have, what the genetic defect causes. Does it cause a malfunctioning protein, a missing protein? And that really gives you then the goal of the gene therapy, what to do with the transgene in the cell. Here's an example of some approved AAV9 therapies already. The first ones that have been approved were in the hematology field for hemophilia B and A. Those were not AAV9 vectors because they did not have to go into the cardiomyocytes. Those were AAV5 vectors. In the neuromuscular field, there's 2 approved agents right now. There's Zolgensma, which is a treatment for spinal muscular atrophy. That's an AAV9 vector because of its not only cardiomyocyte, but also muscular atrophy. And for Duchenne muscular dystrophy, we have 1 agent as well approved right now. There's a lot of investigational AAV therapies right now out there, and I'm going to show the ones that are right now under investigational within trials. So again, in hematology, we have another treatment for hemophilia B. We have for methylmalonic acidemia in the metabolic field, an agent that is under investigation. Some for neuromuscular diseases, but most importantly for us as pediatric cardiologists, the 2 cardiovascular vectors that are out there in the clinical trials is for Danon disease and for the MYBPC sarcomeric hypertrophic cardiomyopathy. So those are exactly the ones that are going to treat the patients which Andrea and Alessia have reported on. Those 2 companies have completed their phase 1 for those indications in Danon disease using the AAV9 LAMP2B gene vector, and in MYBPC3 HCM using a vector that contains the transgene that would produce the deficient myosin binding protein C in the sarcomere. And both those trials have shown decent safety and efficacy results in their first few patients that have been treated with those vectors. So this is just the example of the gene therapy that we use for Danon disease, for example. And Alessia has pointed out that there is a very dramatic disease course in male patients affected with here within the first 20 years, rapid decline in cardiac function that leads to cardiac transplantation or death. And I wanted to show you an example of what this gene therapy did in the phase 1 trial. And this has been published last year in the New England Journal by the authors. And what it shows is that those patients, the male patients, do not express any protein in the beginning of the therapy. This is shown here on the baseline. There's no bar at all in those 7 patients shown here. After gene therapy at months 6, 12, 30, and 36, and this is how long this phase 1 has gone in their follow-up, you see that those bars are increasing, and this is the expression of the protein in the myocardial tissue. So those patients have undergone endomyocardial biopsies at baseline, showing no expression of the LAMP2 protein at all. And in the following months 12 and 18 specifically, there was expression in almost all of these patients. This is promising because it can show us that this therapy works. However, of course, we do not know yet how long this expression will last. They followed the phase 1 trial with a phase 2, which is currently enrolling. This is an example of one of our patients whom we enrolled, and this is an ongoing trial right now, and we hope that within the next few years we will get a lot of information out of this trial. What are the problems now? This now sounds beautiful, and it sounds like, wow, we can treat the genetic disease and we are done, right? So not this easy. Of course, the delivery system causes some reaction to the body. And basically, it is an immune reaction as we all have on every viral infection, just that the naturally occurring adenovirus would not cause a hyperreaction of our bodies. That's like a regular cold. However, if you transfuse a huge amount of it, which we do in gene therapy, there can be a massive immune reaction against this capsid. Also against the transgene, because that's also a foreign body considered by the cell. So there's immune responses that occur very quickly within the first few days after therapy, and those are responsible for most of the safety problems that we see in gene therapy. And to name the three common ones, it's the thrombotic microangiopathy, it's myocarditis, and hepatitis. And I will show a little bit more about how this looks like. Just to summarize all the side effects of all different AAV therapies that have been published so far, and this includes, again, the hemophilia trials, the neuromuscular trials, and the cardiovascular trials. There is hepatotoxicity seen in almost all of them. There is thrombotic microangiopathy seen in also almost all of them. Thrombocytopenia as an isolated finding in some of them. And excessive immune stimulation, such as capillary leak and others, and SEERS in some of those factors. Very few, amazingly, showed myocarditis or just isolated elevated troponin I, which I find amazing, just it's because those vectors are very cardiomyocyte specific, as we learned. Because not all of us might be very familiar with thrombotic microangiopathy. We've learned in medical school, but it's been a long time. Just to show you an example, it is a disease such as HUS. Basically, it goes along with endothelial hyperreaction to an agent. You have a sudden platelet drop. You develop these schistocytes or fragmentocytes, which are these sickle cell-like erythromyocytes on the blood smear. And basically, it clots the microvasculature and causes renal failure, such as that the patients would need renal replacement therapies if they're being hit by this most severe safety issue in gene therapy. So what can we do in order to avoid those reactions or this immune hyperreactivity to the AAV therapies? We can target the immune system, and we have two different immune systems, innate and adaptive one. So right now, the most commonly used regimens to condition or precondition patients who receive AAV9 therapies are applying rituximab to target the B cell reaction, sirolimus to target T cell adaptive immunity, and corticosteroids to target both the innate and the adaptive immune system in order to decrease hyperreactivity to these AAV9 capsids. 2 years ago, they've published how these patients do with and without immune modulation. And this is showing complement activation as well as IgG and IgM activation. And the black dots are the patients who did not receive any immune modulation prior to therapy, whereas the red triangles are the patients who did receive rituximab and corticosteroids and sirolimus. And it showed clearly a decreased B cell response on those that received immune modulation. So with this, there was a huge workshop done, and some very smart people sat together and published kind of a regimen that you could use in order to avoid those very dramatic safety and side effects of the gene therapy trials. And this is just a picture to show you that it is pretty complex. We need to do a lot of surveillance with these patients. We need to really admit them and watch them very closely clinically. We need to do a lot of blood work on those and really detect those side effects very early on in order to be able to treat them and to avoid renal failure or any major organ dysfunction. To prevent those, I've already told you we can start immune suppression, and we do that prior to infusion. However, there's other things that the companies can do. For example, they can optimize their product, their AAV product. They can avoid high doses, and we can exclude patients that are intrinsically prone to thrombotic microangiopathy or HUS. Once we develop problems, we can, of course, intensify our immune suppression. We can give high-dose corticosteroids. We can give C4 inhibitors, such as eculizumab. or just use symptomatic treatment, such as putting them on dialysis until the kidneys have recovered from their injury. So the take-home message is for today, I'm going to delete the hype of the title that Georgia threw out there. Gene therapy is clinical reality. We're using it not only within clinical trials, but also there's approved therapies, as you saw. There's an ongoing process to improve safety and efficacy of those therapies. Other delivery systems other than adenovirus systems are under investigation, and those need to be investigated. For now, AAV is the lead delivery system, and we do know that high-dose administration, although it does improve efficacy, will also result in increased toxicity. But we have also learned how to manage those issues. So with this, there's hope for the future. And I thank all my entire team, and of course the ERN for inviting us, and Georgia and Jacopo for hosting this wonderful session. Thank you so much.
Thank you, Cordula. I think this is amazing now that we know who to call when we are desperate. Okay. So thank you. And I don't know if there are no questions or that they don't charge in the system. I'm quite worried because not even one looks weird. But Jacopo, is there any question to go?
Yeah, so I think I've been thinking a lot because, of course, we shared a trial with Cordula, and we had a very complicated Danon patients, and so even though our N is equal to 1 with gene therapy at our institution, that has taught us a lot. The first question I have is for everyone. I don't know whether there is an answer. Is what is the real sort of benefit one may reasonably expect to achieve in a structural cardiomyopathy, in a structural heart disease that has developed over many years with gene therapy? Because this is something that, if it's electrical, if it's a channel, if it's a blood disease, if it's a disease of the blood, like hemophilia, if it's something having to do with the production of an enzyme in the liver, you can probably how far you can get. But the point is, at this point we're now offering to patients a treatment that is quite sort of engaging in terms of also potential risks, inflammatory risk, and we don't really know what our endpoint is. So apart from protein expression, maybe some reduction in LV mass, little measurements of minor, 0.1, 2, 3 points improvement in function. Do we know how far we can hope to achieve a result? That's the question for everyone. I'm not sure we have an answer here.
Well, I think that's very interesting, and I was wondering, I was thinking about exactly the same when we thought about doing the gene therapy in our patient and our child that's going to be done in a couple of weeks, and really that, for example, we have a biopsy prior, and with very little expression of the protein. So is one of the goals to see that we have more expression, or it's just a lab result that we want to improve? And how far after gene therapy transfer should we do that to see expression? So these are the things that I was wondering how we are going to quantify the good result on that, because we know that arrhythmias might be easier. A lot of arrhythmias, 0 arrhythmias. But with cardiomyopathy, it's just so. I really put that question in my mind. I wonder what Cordula can add on that with her experience.
I mean, what they've published from the phase 1s, and these results, Jacopo, is that the patients felt better, that there was clinical improvement of their heart failure signs and symptoms. There was decrease in LV masses, along with clinical improvement. However, I would say that we all know how difficult it is to assess clinical or cardiac failure in a non-blinded, not randomized study, right? This is an open label study. and patients might just feel better by just knowing that they've undergone therapy, and so on and so forth. I'm not saying that this might be the case now for these patients, but I mean, I think we don't know until it's a randomized blinded trial, which obviously in gene therapy is almost impossible to do.
Yeah, I mean, the placebo effect here is probably massive because you have so much hype that you are bound to feel it. We have a huge placebo effect in the myosin inhibitor trials anyway. Because the second question would be, what is the level of safety you would be prepared to risk in exchange? Again, just because the end result is not clear. I did speak to Barry Greenberg, and I know that there's interesting result in Danon, for example, in the longer term. However, I think we should probably be very stringent on the safety profile of these therapies in narcotic patients until we know more about the long-term benefits.
The only thing I would add, though, Jacopo, is that we, of course, as you guys presented from your own patients, we do know that the natural history is very severe, at least in the Danon population, in the male Danon population. So if you think that just those few patients from the phase 1 have survived so far, even if they had no clinical improvement of their heart failure, but they did not undergo transplantation or passed away from their cardiac situation, that probably per se would already show, a clinical benefit of the therapy. It is probably different in other sarcomeric HCMs. I mean, the patient that you guys are treating in Barcelona, she's a very severely affected one, but she's also not representative for most of the sarcomeric HCM population. So, and with this, I totally agree. Would we want a patient with a regular HCM, sarcomeric HCM, undergo gene therapy with the safety issues that we face right now? We probably would not, because we have other things in our hands right now to treat them with. But in a few years from now, once we've improved the delivery systems and we've learned more how to really safely administer the drug, I think that would be a different story.
I think we have 2 questions from the audience.
Yeah, we have 3 new ones. So, okay, so Miguel, hello, Miguel. So it's a former fellow. Thank you very much. And I think that his question is, other than histology changes, do you think that there is a change, that we might expect changes in the MRI with the late gadolinium enhancement, secondary to the improvement in the protein? So if that would be probably an endpoint for that. So what do you think? What is your impression? Yeah, but it's the idea of, do we have a reversible effect on the fibrosis? Because actually, when we see late gadolinium enhancement, it's part of what we see. It's that dead tissue, and would the gene therapy improve that? I have the feeling that's a scar, and that scar, it's difficult to reverse. But they have explained, at least with the Tenaya gene therapy, they have explained that there was an improvement on the amount of fibrosis that they were seeing in the MRIs. So I don't know how we can quantify that. And would you expect an improvement on the late gadolinium enhancement in the MRI?
That's for me?
Yeah.
Okay. Yeah. No, I would not. I mean, it's not in the short term, but you would expect, a lesser degree of increase or a less progression. I don't think you can expect to have, unless you have, actual removal agents. I think somebody's working on that for the liver or for the lungs. So the removal of fibrosis, and also for post-myocardial infarction scar. I think there's research going on there, but here what you're doing is stopping the disease. You're trying to stop the progression of disease. You're not turning the clock backwards, unfortunately. Not because in order to do that, you would need to enroll very, very mild initial cases, which would not have an indication for that. So we're always stuck in this catch-22. The patients have the most benefits are the ones you would not enroll because they're just too mild. And so you enroll patients that already have some evidence of severe disease, which justify the risk and enrollment, but those are the ones that have less reversibility of their changes. That's my impression.
We have a comment from Janeki Kamerat, that she wonders, what do you think that how long after gene therapy the immune suppression is needed? Normally, we said it's about 6 to 9 months of immune suppression. It's 2 weeks before and 6 to 9 months after. Is that the same for the protocols you have used, Jacopo or Cordula?
No, it's less for the steroids. So rituximab will depress your B cells for about 6 months by those 2 or 3 administrations in those 2 weeks prior to therapy. And sirolimus and corticosteroids was only being continued for up to 12 weeks, and we tapered pretty fast in the steroids because of the side effects. However, if there's any signs of liver dysfunction, any concern for hepatitis, you have to boost really immediately with corticosteroids because of the risk. There was a fatality in the Zolgensma trial, and those were all hepatitis. I think the 2 or 3 kids that passed away. So we've learned from those patients.
Mm-hmm.
But after 6 months, I would say the cells should have recovered or are going to recover. I don't know about Jacopo's experience.
I think Alessia is the person here because she's on the technical.
Yeah.
Our patient had complications, so we had to treat forever.
Yeah, the patient was on steroid for really a lot of months. So it depends on the protocol, but I totally agree with Cordula. It's usually 3 months for the steroids, but then whatever complication comes out, you need to boost the steroids. So it can be very variable on the basis of the patient's response.
Thank you. And we have a question from Ruth Filler that about the gene therapy in ARVC and arrhythmogenic cardiomyopathy, given the fact that there are probably autoimmune factors and that infections or vaccinations seem to trigger the disease, what would be the role for gene therapy for those patients? I think that I think we know that there might be triggers or accelerators for the disease, and the underlying condition is a genetic background that has already started. Otherwise, as Jacopo said just before, we would not even consider gene therapy, and assuming those risks, we would be dealing with severe sick patients, either children and adults. But would you add something, Cordula, for that?
Well, I mean, there are trials going on in ARVC for PKP2, and that's public, and that's on clinicaltrials.gov. And I think, Ruth, I understand your point. However, if you are replacing a malfunctioning protein and causing less autoinflammation, I think you might also be able to treat ARVC or arrhythmogenic cardiomyopathies with gene therapy. I think the same issue, though, remains that a lot of those diseases would present not until much later in life or early adulthood or later adulthood. And so the question will be, when would you undergo a risky therapy like gene therapy to treat the disease?
It's also more for DSP, isn't it, rather than PKP2? I guess the link is tighter in DSP cases. And also, I don't think we still know what the deal is really for ARVC, in the sense that, of course, as Ruth is pointing out correctly, there is definitely a link with some immunological triggers. But for example, during the COVID, I was so scared for my arrhythmogenic cardiomyopathy patients. And I had, some of them got bad COVID and nothing really sort of happened. So it really is a matter of, we still don't know. I mean, there may be something else that we are missing. It's not so straightforward. So vaccine or COVID equals flare of the disease. It's nothing like that.
Mm-hmm. Okay. Thanks, and thank you very much. And I think that this has been a great discussion. I think that for the coming month, many things will happen, and I think it's an exciting moment. So definitely we can say that there is hype and of course clinical reality both, and they are not contradictory. I think this is not a dichotomy. I think the future is here. I think this was science fiction not so long time ago, and we have the pleasure and the privilege of being part of it. And I think I feel blessed for that, and I think that we are here. We are in the reality, and I'm really proud of being a part of at least the spectator or the people who will be able to see this. So thank you very much. Jacopo, would you like to close the session?
Oh, yeah, I just echo your words. And it's one of the many reasons why I would like to be 20 or 30 years younger. Because, but thank you so much. And thank you for organizing this and having us. And thanks to Andrea, Alessia, and Cordula for a great job. And I hope to see you soon, very soon.
Okay. Thank you very much.
Bye-bye.
Thank you.
Bye.
Thank you. Bye.
Thanks.